the management of glaucoma in order to prevent blindness caused by glaucoma. To date, many medical and surgical treatments have been developed to reduce IOP. However, glaucoma is still the leading cause of blindness in the world. And there are many patients with refractory glaucoma, in which IOP reduction is difficult to achieve. This is why we have to continue in an effort to create novel therapeutic approaches to lower IOP. I'm glad that we can demonstrate various approaches to IOP reduction in this session and share new information on future treatment of glaucoma with all of you. Speakers for this interesting session include Dr. Honjo from Japan on trabecular meshwork scouring and lock inhibitors, Dr. Overby from UK on shear stress and NO in Schrem's canal, Dr. Sakata from Japan on new uveoscleral treatment targets, Dr. Huang from the United States on subconjunctival outflow and brave biology, and Dr. Han on tubes, mitomycin C, and microfluidics. Also, we are expecting active discussion after all talks, so we would like to go on to the first talk.
Thank you for this opportunity to speak here today. I also appreciate organizers and chairs. This is a disclosure slide. Here is the outline of my presentation. I'd like to speak today's topics, dividing into two parts. I'd like to start by giving an overview about the mechanisms of regulation of aqueous outflow resistance and intraocular pressure IOP and its correlation with lock inhibitors. Outflow resistance in conventional outflow is thought to be mainly associated with cellular actions and fibrotic change in trabecular meshwork TM cell, accompanied with deposit of ECM in the tissue and the permeability of endothelial cell lining Schrem's canal. Various mediators are upregulated in glaucomatous aqueous humor and affect these changes of outflow resistance. As shown in the slide, significant accumulation of collagen in the overall TM to Schrem's canal is observed in the human glaucomatous eye specimens. It has been mentioned that this scarring of overall TM tissue may be related to the outflow resistance. So far, several lock inhibitors are clinically available in Japan and overseas. We reported the first topical IOP lowering effect of Y27632 in rabbit eye in 2001 with increase in trabecular outflow facility. Lock inhibition causes alterations of cytoskeletons, cell ECM interactions, regulate phagocytosis, and decrease ECM production and deposition. And also, lock inhibitor increase SCE permeability. Accumulating results have suggested that the low lock signaling is crucial in the regulation of fibrosis and outflow resistance. It has been reported that overexpression of low in right eyes resulted in IOP elevation accompanied with ECM accumulation in TM, which is an almost complete mimic of the pathogenesis of glaucomatous change. We showed another supporting clinical evidence for the involvement of low lock signaling pathway in the ECM synthesis. A long-term treatment with Lipastil, which is clinically available lock inhibitor in Japan, showed an additional IOP lowering effect, especially in those with higher baseline IOP. This additional IOP lowering effect of Lipastil may be related to the modulation of late-onset remodeling of ECM in the trabecular meshwork. This is a summary one. Increased outflow resistance in the conventional pathway result in IOP elevation, and significant accumulation of ECM in the conventional pathway is observed in the human glaucomatous eye. Low lock signaling is crucial in the regulation of outflow resistance in the conventional pathway through regulation of cellular responses and ECM synthesis. In the next, I'd like to move to the topic about the role of aqueous mediators in pathophysiology of glaucoma. I also would like to mention about the potential of lock inhibitors. Among the biological active factors elevated in glaucomatous eyes, TGF-beta, LPA, and S1P reportedly increased the ECM deposition in TM and decreased aqueous outflow resistance in ex vivo experiments. These factors induce various responses, including low regulated cellular responses. Therefore, they may affect aqueous outflow in part through blocked signaling modulation. We have focused on ATX-LPA pathway. LPA is a simple phospholipid generated by the enzyme ATX. It has been suggested to be involved in the pathogenesis of glaucoma by ex vivo study. However, its upregulation in the glaucomatous aqueous humor or actual role was unclear. TGF-beta2, one of the major cytokines to regulate fibrotic response and strong agonist of low-log pathway, is reportedly upregulated in the aqueous humor in POAG patients. But we have also previously reported that it was rather low in other types of open-angle glaucoma, such as SOAG and exfoliation glaucoma, XFG. We recently quantified aqueous level of LPA and ATX and found that aqueous levels of ATX-LPA pathway was significantly high in SOAG and XFG, which show high IOP. We also confirmed the upregulation of ATX-LPA pathway was significantly related to IOP elevation. Then we performed study to determine where and how ATX is produced. Immunostaining of ATX in the human tissue showed intense ATX expression in TM and SOAG, moderate in POAG. Control and NTG specimens didn't show significant ATX expression. We also found significant upregulation and secretion of ATX in TM cells induced by dexamethasone treatment. We suppose that ATX produced in TM cells generate LPA and possibly result in IOP elevation by affect surrounding TM tissue and Schwemm's canal in a paracrine and autocrine manner. To explore the physiological role of ATX in secondary glaucoma, we focused on Posner-Schwarzman syndrome, PSS. PSS is one of the major SOAG with higher rate of elevated IOP, and CMV positive PSS patients are more likely to have refractive IOP elevation. We investigated the level of aqueous ATX and correlation to the elevated IOP in PSS patients. As a result, we found high aqueous ATX or TGF-beta1 levels in PSS patients when CMV positive and having glaucoma, while there were no significant difference concerning TGF-beta2 and 3. As for the correlation with IOP, only ATX were significantly correlated with IOP, and TGF-beta1 didn't show significant correlation. To confirm the relationship between CMV infection, ATX, and IOP elevation, we conducted in vitro studies. ATX and TGF-beta1 was upregulated after CMV infection. We also found that gene expression of ATX precedes TGF-beta1. In contrast, TGF-beta2 was rather downregulated. Conditioned medium from CMV infected TM cells caused fibrotic change in TM cells and decreased permeability in SCE cells. Our findings support the hypothesis that dysfunction in TM induced by CMV infection causes rapid changes in aqueous outflow resistance, causing extremely elevated IOP. LOC inhibitor showed significant effect against the increased outflow resistance. In the clinical study, we reported the supportive evidence for the effectiveness of LOC inhibitor in the pathogenesis of SOAG. The Basileus showed effective IOP lowering in SOAG, especially in vertic glaucoma and steroid-induced glaucoma. We further conducted prospective study to determine the detail of characteristic upregulation of each mediators in aqueous humor. As shown in the slide, ATX TGF-beta1 and TGF-beta3 was high in SOAG and XFG, while TGF-beta2 was high in POAG, but low in XFG. ATX TGF-beta1 and 3 were positively correlated with IOP, whereas TGF-beta2 was not. Among 4 mediators, only ATX was significantly and negatively correlated with the mean deviation. In the initial study on ATX, we found that the aqueous ATX was useful in differentiating glaucoma from control and SOAG from POAG. Using machine learning methods, we recently reported that high AUC values using 4 variables, the aqueous balance of the mediators could be promising biomarkers for glaucoma. Most recently, we also have reported that the TGF-beta2 may regulate ATX expressions in TM cells in a concentration-dependent manner. This may reflect the characteristic upregulation of these mediators in glaucoma subtypes. This is a summary too. ATX-LPA pathway, an agonist for low-lock signaling, was upregulated in glaucomatous aqueous humor, especially in SOAG and XFG. We also have found the crosstalk between the TGF-betas and ATX-LPA pathway. Various signaling cascades are involved in IOP regulation and glaucoma pathogenesis. Among them, many mediators which stimulate low-lock signaling pathway play an important role in the pathogenesis of glaucoma, suggesting the potential of LOX inhibitor as a glaucoma drug, not only to lower IOP, but also challenge the pathological change of glaucoma. This is my last slide. I'd like to thank all my colleagues and lab members, especially Professor Aihara, who is my mentor and chair local of this meeting. Thank you for your attention.
So I'd like to thank the organizers for the invitation to speak at this excellent meeting. My name is Daryl Overby from Imperial College London, and my talk today will be entitled Shear Stress and Nitric Oxide in Schlemm's Canal. I'd like to thank the members of my lab, especially Esther Reyna-Torres, and Jason Chang, who did all of the work that I'll be describing today. Now, nitric oxide, or NO, is a soluble diatomic gas and is a biologically active molecule that's important for a number of physiological functions. And we know from several studies that nitric oxide could be used to lower intraocular pressure. Lysolta, for example, which combines nitric oxide release with a prostaglandin analog, lowers IOP, as do other nitric oxide donors, has been shown in monkeys and other species. Now, it's believed that nitric oxide lowers IOP by targeting through regular outflow pathway to increase outflow facility, as nicely demonstrated here in pig, but similar findings have been shown in monkeys, rabbits, and mice. Now, I'll point out in all of these studies, nitric oxide is delivered exogenously by a drug or NO donor. Now, in the vascular system, nitric oxide contributes to the regulation of vascular tone. Shear stress, which is the frictional force exerted on endothelial cells as a result of blood flow, stimulates nitric oxide production. This involves endothelial nitric oxide synthase, or eNOS, which produces nitric oxide that then acts on the surrounding smooth muscle cells to affect their contractility and drive relaxation. And this mechanism is responsible for shear-induced vasodilation. Now, in the conventional outflow pathway, endothelial cells lining Schlemm's canal is surrounded by trabecular meshwork cells, which, like smooth muscle cells, are known to be contractile. We know based upon Rho kinase studies that this contractility is important for outflow function. Now, Schlemm's canal cells also express endothelial nitric oxide synthase, as shown here nicely in mice. And Schlemm's canal cells express nitric oxide or increase their production of nitric oxide in response to applied shear stress. Further, if we overexpress endothelial nitric oxide synthase, we can lower IOP in mice. Now, this leads us to think that nitric oxide may be physiologically involved in outflow regulation. Just leads us to a few key questions. First, what is the evidence for endogenous nitric oxide signaling in the outflow pathway? And second, how can this nitric oxide signaling contribute to IOP homeostasis? And by homeostasis, the idea here is that there's some set point in intraocular pressure that the outflow pathway tries to maintain. Now, any homeostatic mechanism requires some mechanism to sense and respond to perturbations in intraocular pressure, and a response that then opposes that direction of IOP perturbation and ideally increases in proportion to it. And in this talk, I hope to convince you that nitric oxide is a signaling molecule involved in IOP homeostasis. Now, there's already evidence in the literature from Schneemann and colleagues that elevated IOP stimulates nitric oxide production in the outflow pathway of human anterior segments, and LNAM, which is an inhibitor for nitric oxide synthase, abolishes this effect. But this study cannot localize where in the outflow pathway nitric oxide was being produced or whether it had any meaningful effect on outflow function. Now, to localize nitric oxide production, we developed our own nitric oxide biosensor. This biosensor detects nitric oxide based upon the conversion of tyrosine to nitratyrosine, which only occurs in the presence of nitric oxide. We designed several tyrosine-containing peptides which respond in a nice dose response with increasing nitric oxide concentration. We then took these peptides and coated them onto a microbead here, the idea being that we can localize nitric oxide detection based upon the acidity of the microbead location. So in the presence of nitric oxide, the peptides are converted to nitratyrosine, which we can detect using a primary and secondary antibody. To validate this biosensor, we place these microbeads into the perfusion fluid with shear flow acting on human umbilical vein endothelial cells. The cells align nicely in response to shear, as is well known. And we also measured a nice increase in the signal from our biosensor, suggesting that we're able to detect nitric oxide or shear-induced nitric oxide production by HUVEX. I'd like to also point out that the microbeads themselves are fluorescent at a different wavelength than the nitratyrosine signal. So we can then implant the microbeads within the trabecular meshwork to locally detect nitric oxide production within in situ. This is a diagram of our setup here. The eye is shown here. We take eyes from black 6 mice that were enucleated and perfused in a water bath at 35 degrees C. Now, the eye was cannulated with 2 needles. This allows us to rapidly deliver the microspheres of the microbeads as shown here in pink to the anterior chamber. Using an actuated reservoir, we can control the pressure in the eye and perfuse at either 8 or 16 millimeters of mercury. The eyes are perfused overnight to give enough time to accumulate nitratyrosine. The eyes are then fixed and immunolabeled for nitratyrosine and imaged by confocal microscopy. So here's a flat mount image showing anterior segment cut into 4 quadrants. The beads themselves have their own fluorescence, which allows us to measure the distribution of the bead labeling in the trabecular meshwork. And we can separately image the nitratyrosine signal, which is proportional to the local nitric oxide production. And we can apply some image processing tools to isolate the fluorescent signal from the trabecular meshwork only, eliminating the signal from elsewhere, and we can apply the same mask to the nitratyrosine signal. Because the nitratyrosine intensity will naturally depend on how many beads are at any particular location, we divide the nitratyrosine signal by the microbead signal to get what we call the corrected nitratyrosine intensity. These are images showing the corrected nitratyrosine intensity for 3 cases, ranging from blue, which is a very low nitratyrosine level, to red, higher. You can see in the negative controls, which have emitted the primary antibody, they have a very low signal. A modest signal at 8 millimeters of mercury, mostly blues and greens, that increased to mostly reds at 16 millimeters of mercury. And so this is indicating increased nitric oxide production in the trabecular meshwork in response to elevated intraocular pressure. We can quantify that with a histogram, and we're seeing a rightward shift from 8 to 16 millimeters of mercury in response to elevated IOP. This is for 1 pair of eyes. Similar data were observed in 5 other pairs. We're quantifying here the median value in this histogram and how that median value increases going from 8 to 16 millimeters of mercury. And we see roughly a 12% increase in the nitratyrosine signal, which was statistically significant. We then repeated the experiment in the presence of LNAM, which is an inhibitor of nitric oxide synthase. Both eyes in this case were perfused at 16 millimeters of mercury with or without 50 micromolars of LNAM. You can see a high nitratyrosine signal in the vehicle that then is reduced with LNAM. We can then quantify that by a downward shift in the distribution and also in the median value, showing roughly a 29%, 30% decrease in the median in response to LNAM. And so what this is showing is that the nitrotyrosine signal, which we're using as a readout for local nitric oxide production in the trabecular meshwork, depends upon nitric oxide synthase, as one would expect. So this leads us to think about the role of shear stress in Schlemm's canal. Now, at normal intraocular pressure, there is circumferential flow in Schlemm's canal, and this will generate some amount of shear stress that acts on the endothelial cells. However, as IOP becomes elevated, we know that the lumen of the Schlemm's canal narrows, and this will increase the shear stress that acts on Schlemm's canal cells, driving the production of nitric oxide, which then acts on the surrounding trabecular meshwork cells to potentially modulate outflow function. Now, this is similar to how nitric oxide functions in the vascular system we showed previously, but our nitrotyrosine biosensors allowed us for the first time to measure nitric oxide production in the trabecular meshwork in situ to show this mechanism actually happening. The question then becomes whether this endogenous IOP-induced nitric oxide signaling has any meaningful effect on outflow. To answer this question, we measured outflow facility using the eye perfusion system. Briefly, this exposes the eye to incremental pressure steps while measuring the flow into the eye at each pressure. And we looked at two cases. The first were two eyes from a control, two paired eyes from a mouse fused with vehicle. We see a nice overlap between the flow and pressure because two paired eyes have the same facility. In response to LNAM, we see a reduction in the flow rate at each given pressure. Now, if we quantify the outflow facility simply as a ratio of flow and pressure, we see that there's no change in the facility in the eyes perfused with vehicle alone. However, if we treat with LNAM, we see a pressure-dependent reduction in outflow facility. And what this means at 8 millimeters of mercury was not detected statistically significant, while at 20 millimeters mercury it was. And so taken together, these data suggest that there's endogenous nitric oxide production in response to elevated IOP. So in conclusion, we've shown evidence for an IOP-dependent nitric oxide signaling in the outflow pathway, and that nitric oxide is a physiologically significant effect on outflow facility. So I'd like to leave it there. I'd like to thank you for your attention. And again, I'd like to look forward to any questions in the live session. Thank you very much.
I am Rei Sakata from the University of Tokyo. Today, I would like to talk about new uveoscleral target treatments. I have no conflict of interests. The effectiveness of IOP running therapy has been known for more than 20 years. In patients with NTG, 30% IOP reduction was found to inhibit progression in about 80% of patients. The general strategy for IOP management. Horizontal axis shows glaucoma stage, and vertical axis shows the progressive speed or IOP level. You can see that glaucoma eye drop therapy is involved on many occasions. The target IOP is determined based on the glaucoma stage, baseline IOP, age, glaucoma progression speed, and other risk factors. This target IOP will be adjusted as necessary based on the progression speed. The ideal first glaucoma eye drop would include a strong IOP lowering effect, low burden on daily life, fewer adverse effects, and is easy to enhance treatment. In this sense, FP agonists can be said to satisfy almost these requirements. This table shows the effect of FP agonists on the IOP lowering effect in NTZ. The blue box indicates an IOP reduction of over 20%. On the other hand, local side effects have become a cosmetic problem in FP agonists. These include deepening of the upper eyelid sulcs, DEWs, atrophy of the orbital fat, and concavity of the eye, lower eyelid flattening, lower scleral exposure. Although these changes do not affect glaucoma progression, it is a major cause of loss of quality of life. These are the typical cases of upper eyelid change. As you can see, the upper eyelid has become deepened after using FP agonists. A similar problem was reported about 10 years ago, but this has nothing to do with eye drop use. These upper eyelid changes had a negative impact on glaucoma surgical outcome. This report showed that eyes with dews resulted in poor postoperative IOP control. Let me change the subject. In 2018, a new mechanism eye drop, omidinipag isopropyl, became available in Japan. This eye drop selectively binds to EP2 receptor. Basic research showed that it acted not only on the uveoscleral pathway, but also on the trabecular meshwork pathway. EP2 receptor agonists have shown no inferiority to FP receptor agonists in lowering IOP. In this 1-month trial, no serious side effects were observed. The new administration of AP2 agonists to Japanese glaucoma in clinical practice significantly reduced the IOP at 3 months. This is a mean IOP change from baseline, which was a long-term phase 3 study in Japan. The mean change in IOP from baseline in each treatment group showed significant IOP lowering effects from 2 weeks after treatment and remained stable until 52 weeks after treatment. The effectiveness of EP2 agonist switch in patients with non-responder to latanoprost was shown. The mean change in IOP from baseline during the treatment period was about minus 3 mmHg in 4 weeks. The table shows the frequency of occurrence and outcome of major adverse reactions in Japanese patients treated with EP2 agonists. The frequency of hyperemia was high, and corneal thickening, macular edema, and iritis were reported. All cases occurring macular edema were in the eye with an intraocular lens. Representative cases of macular edema are shown. This is a case with visual acuity loss 37 days after starting EP2 agonist. Discontinuation of eye drop from phenac eye drops, oral acetazolamide showed effectiveness. In the right case, visual acuity decline had occurred in 152 days. Bromfenac eye drops did not affect the macular edema. Discontinuation of eye drop and STTA demonstrated effectiveness in about 3 months. This data showed changes in hyperemia scores in healthy adults in the phase 1 clinical trial. As shown here, hyperemia peaks at an hour after administration, persists for about 4 hours, then disappeared in 8 hours in most cases. This is a long-term data of CCT in patients treated with only EP2 agonists. After administration, there was a continuous increase in CCT, about 10 to 20 micrometer over the 52-week treatment period. Left figure, FP agonists can cause inhibition of fat production. This is a cause of the upper eyelid change I mentioned before. On the other hand, the right figure shows that EP2 agonists did not inhibit fat production. With the result of this basic research as a background, we conducted a clinical study. This patient had been using FP receptor agonists for 8 years and aware of the upper eyelid changes. After changing from FP receptor to EP2 agonists, Her eyelids showed marked improvement in only 4 weeks. In summary, in addition to FP agonists, selective EP2 agonists can be used for glaucoma treatment in Japan. In clinical trials, EP2 agonists are reported to be non-inferior to latanoprost. It is necessary to accumulate more clinical findings. DUES, which is a major cosmetic problem with the use of FP agonists, might be reduced by switching to EP2 agonists. That's all of my presentations. Thank you for my listening.
Thank you everyone for coming. Today we're going to be talking about subconjunctival outflow as well as bleb biology. Here are my sources of research support, and here are my financial disclosures. In this room, you're all aware of multiple aqueous humor outflow pathways. You know about number 1, the trabecular conventional pathway. You know about number 2, the uveoscleral unconventional pathway. I describe the third pathway as being subconjunctival. What do I mean by that? I mean a direct communication between the anterior chamber and the subconjunctival space. In other words, glaucoma surgery with blebs. This is a low resistance outflow pathway so that you can use surgery to lower intraocular pressure. Now, this isn't native outflow, but at the same time, we use this to treat patients so that improving our understanding may allow us to do surgeries better. Now, like many of the other pathways, there are now MIGS, or minimally invasive glaucoma surgeries for the subconjunctival space. On the left, you have the Zen gel set from Allergan, which has been available for a few years. And on the right, you have the PreserFlow from Santen, which has just received approval in a number of countries. In both of these cases, you're using a stent to create that communication between the anterior chamber and the subconjunctival space, and in both cases, they rely on blebs as well to lower intraocular pressures. So with these surgeries, in addition to surgeries such as trabeculectomies and tubes, you can ask the question, how is fluid getting out of blebs? Now, before we get there, you can also ask the question, what is a bleb in the first place? Because you don't even need a doctor to get the bleb. If you look on the left, patients can get blebs on their own in cases of ocular surface infection, inflammation, or fluid overload. This is just chemosis, and this goes away. In the middle, you have a drug delivery bleb where maybe at the end of surgery, you'll inject a little subconjunctival antibiotics and steroids, and this goes away as well. And then on the right, you have the kind of bleb that we want to stay in last, the glaucoma surgery bleb that's intended to lower intraocular pressure. Now, this has been studied before using tracer-based methods, and the easiest way to do this is all I have to do is punch you in the face, give you a subconjunctive, and in the middle you can see that the blood resolves in sausage-shaped patterns. Scleral tattooing on the right, gone awry, resolves in these patterns, and there has been a handful of case studies where indocyanine green has been injected under the conj showing these patterns. Now, some of the better work has been done by Dao Yi's group down in Perth, Australia, during early Aquasys Zen development. He started by injecting trypan blue under the conj of non-human primates and rabbits, showing these blebs in these outflow pathways. The image on the bottom is performed by Claudia Pan's group in Qingdao, China. Now, Dao Yi hypothesized that these were not blood vessels because they don't have the typical Y-shaped formation and they are irregular in their appearance. Instead, he hypothesized that these are maybe lymphatics, owing in part to the patterns and also because we know that lymphatics are in the conjunctiva as evidenced by 5' nucleoside stain. Dao Yi also felt that these pathways were important for surgery. This is a post-op month 6 rabbit Zen. You can see the bleb forming with fluorescein in the eye. These radial pathways, he believed, are related to just conventional regular outflow. It's these pathways that come off to the side with the squiggly orange arrows that he believes is blood outflow and may be lymphatic in nature. So we got involved in this work a couple years ago where we were injecting blebs and seeing pathways come off. This is work done by Goichi Akiyama in my lab. What we were able to see was that this pattern was conserved across species, pig, cow, humans. You see blebs and you see pathways, and it's conserved across different tracers, fluorescein, indocyanine green, or fluorescent dextrans. If you concurrently performed structural imaging with OCT, either in cross-section or longitudinally, you can see the luminal structure of the pathways. If you place the OCT very carefully along the bleb outflow pathway border, you can identify the little hole that's actually draining the bleb. Now, we wanted to know where these pathways existed, and as a stupid surgeon, all I know how to do is to cut things out. So on the left in A, you have the bleb and the outflow pathway, and then we just excise the conj in B. In C, we re-image the bare sclera. So you see the bleb where it used to be, but the pathway's gone. In D, when we image the cut conj, you find the bleb and the pathway again, telling you that the pathway is within the conj. We wanted to get quantitative and looked at the number of outflow pathways coming off the blebs. If you go by location, we noticed the distinct temporal nasal asymmetry where nasal had more and temporal had least. In B, if you're looking at the number of pathways off all the blebs, most blebs show either one or two pathways. Some of them show none. That's about 18 to 20%. And I always wondered if these are the types of blebs that don't make it if they were actually glaucoma surgical blebs. We also got into a recent question about subtenon versus subconj blebs. This is work done by Jongyoung Lee in my group. You can see in the subconj bleb, it's very yellow, raised, and clearly visible because it's superficial. The subtenon bleb is deeper, so it's not quite as yellow. In our work, the subconj bleb shows many more pathways than the subtenon's bleb. And then further, we replicated the result again with this nasal temporal asymmetry. So where could this asymmetry actually be coming from? Let's assume for a second that indeed these are lymphatics. So this is work done with Young Kwong Hong's group in collaboration with my lab. We have transgenic mice with natively fluorescent lymphatics, and we did a developmental analysis showing that the lymphatics start from a nasal root, a trunk, and then wraps and grows around temporal. This is development. In the adult eye, the nasal side has more lymphatic sprouts compared to the temporal side quantitatively. This is structure. Functionally, also the nasal side seems to show more lymphatic outflow. When we inject albumin red under the conj, the nasal side clears it much quicker than the temporal side is shown here. So this developmental idea may explain this temporal nasal asymmetry. Now back to our larger species, where we really want to say, are these pathways indeed lymphatics? And so we first took a structural approach using 2-photon microscopy. You see the outflow pathways with blind end tips. That's very suggestive because lymphatics have blind end tips. And then if we do OCT on the bleb as well as the outflow pathway in the direction of flow, so that's red, blue, yellow arrow, in the direction of flow, you see semilunar bicuspid valves. And again, this is structural evidence because lymphatics have valves. We then took a molecular approach using fixable fluorescent dextrans. These are fluorescent tracers that we can see on angiography, and then they're fixable because with fixation we can trap them in place so that after trapping we can cut the histological section, say at the yellow arrow, and re-identify the exact outflow lumen again. If we do immunofluorescence against lymphatic markers such as PROX1 and podoplanin, we see colocalization. If we do immunofluorescence against a blood vessel marker such as CD31, you see complete dislocalization between P and Q, saying that these pathways are not blood vessels and instead, from a molecular standpoint, lymphatics. We then moved to live humans, and we took advantage of the fact that people with retinal diseases such as macular degeneration need intravitreal injections. Now, before the injection, they need anesthesia, and many retina doctors like to use subconjunctival lidocaine as the anesthesia. So under UCLA IRB approval, what we did is we mixed the ICG with the lidocaine for the anesthetic step and then to serve as a tracer for outflow imaging from the subconjunctival space. Now, first, let's just talk structure initially. No tracer. In the normal eye, the conjunctiva is very thin in A with a very superficial conj scleral border. In B, you have a trabeculectomy eye. We're not focusing on the bleb, which I'm showing you on the insert. Instead, we're focusing away from the bleb. What you see is a very thickened conj in the yellow barbell, dilated lumens, and valve-like structures, or septae-like structures. In C, you have an individual getting subconj lido without the tracer, just the lido. Again, thickened conj, dilated lumens, valve-like structures. In D, an individual with chemosis, extremely thickened conj, very dilated pathways, and the green arrows show valve-like structures. In the tracer study, from A through D, we can see the blebs. In B, the blebs is a little more inferior, and you can see that the bleb-related alpha pathways are very irregular. Right-angle turns, U-turns, some Y-shaped branching as well, and you see that the pathways are sausage-shaped, thick, thin, thick, thin. This is all in contrast to E and F, which is conventional outflow imaging because the tracer is in the anterior chamber, where you get the more classic Y-shaped branching, as well as pathways that are even caliber throughout. OCT on the bleb-related outflow pathways show you the lumens. These pathways can get very complex like a web, and OCT, you can also break them into the individual arms as well. If we really focus in on the pathways themselves and perform the OCT on regions of thick, thin, we can then again in live humans now see valve-like or septate-like structures within these bleb-related outflow pathways. This is in contrast to conventional outflow imaging with aqueous angiography, again, where you see more even caliber pathway, and then the lumens are actually valve-less. We wanted to then test, can we manipulate these pathways that we're calling lymphatics now? So we went back to our rodent system with the natively fluorescent lymphatics. We had an injection protocol of every other day with sacrifice at day 7. The NL is basically non-injected control. Balanced salt solution is an injection control. And VEGF-C was a drug we used as a lymphatic proliferative agent. We also tested anti-metabolites we typically use during glaucoma surgery that have been hypothesized to damage lymphatics. And what you can see is the balanced salt solution alone grows some lymphatics. This is likely due to trauma-induced lymphangiogenesis. VEGF-C induces tremendous lymphangiogenesis, and then the anti-metabolites may be knocking it down. Quantitatively, looking only at the superior quadrant, which is where we're injecting, you can see for branch number and branch length, the lymphatic branch number and branch length go up as we go through trauma to VEGF-C, and then down with the antimetabolites, suggesting that we can manipulate these pathways. So in conclusion, fluid and blebs, long known to go somewhere, long suspected to be lymphatics. Our only role up to this point is that in multiple species, vertebrates, we have provided very good evidence that, in fact, lymphatics drain the subconjunctival space. The current question now is whether or not glaucoma surgeries absolutely require these lymphatics, and if they do, how do we promote this? For example, can VEGF-C be used as a way to grow lymphatics into blebs to help them function better? Thank you very much.
Thanks, everyone. It's my great pleasure to join the meeting, and I want to thank the meeting organizer committee to invite me. It's my great pleasure. The title of my talk is Glaucoma Drainage Devices, Tips for Better Success. So the use of a glaucoma drainage device is on the rise. It's especially for patients with secondary glaucoma or high-risk populations. Tube shunt surgery is easy to use and has lower immediately post-op complications in some of the tube shunt surgeries compared to trabeculectomy, so has been broadly used. However, there are also issues with tube shunt surgery. So in this talk, we're going to discuss 2 problems may associated with tube shunt surgery. One is how to prevent cornea decompensation. The second is how to prevent hypertensive phase and improve long-term success rate. This is especially for Arment glaucoma drainage device. So how to preserve cornea? So we can place a tube away from cornea. That's the general concept. Passband tube placement has been advocated to protect against a significant cornea endothelial loss. However, it requires a concurrent or prior vitrectomy procedures, which commonly performed by retinal surgeons. So we advocated tube place in the sulcus space. So as showed in this figures, the sulcus tube is behind the iris, but in front of intraocular lens. So here's a video to show how we place the tube into the sulcus. So first we trim the tube with bevel down configuration, and then we fill in the sulcus with viscoelastic. So that means injecting viscoelastic behind the iris above intraocular lens. Then we use 20 gauge MVR blade to enter the sulcus at 4 mm from the limbus. After that, we inject the same track with viscoelastic to smooth the path. After that, we insert the tube. So after we insert the tube into the sulcus, we want to see the tip of the tube, which should be located behind the iris and in front of intraocular lens. So in order to achieve that, we recommend dilate the patient's pupil for this purpose during the surgery. So we conduct the study to compare endothelial cell loss for patients with AC tube versus a sulcus tube. So for those cohort of patients, we have over 100 eyes for each group. Every baseline characteristics are comparable except follow-up time. So in order to compensate for the follow-up time, we calculate the monthly endothelial loss rate by follow-up endothelial cell density, subtract the baseline endothelial cell density divided by follow-up period time. And we find out the endothelial cell loss rate is significantly decreased in the patient receive sulcus tube compared to patients who receive anterior chamber tube. And in the multivariable analysis, sulcus tube location is still a significant variable to protect corneal endothelial cell loss. So in summary for this session, we find compared to anterior segment placement, ciliary sulcus tube implantation may be a preferred surgical approach to reduce endothelial cell loss in pseudophakic patients. Future clinical trial is under plan to further study this question. Second part of my talk, I want to discuss how to prevent hypertensive phase and improve long-term IOP control. So mitomycin has been broadly used in the glaucoma surgery. It's prevent fibroblastic perforation and the lymphocyte activation to prevent fibrosis. 3 published RCT randomized clinical trial examined mitomycin in aqueous shunt study, and they find that using intraoperative mitomycin does not help improve surgical success that much. It only helps at the beginning 2 or 3 weeks immediately after the surgery. So that means single use of intraoperative mitomycin may not work as we did for trabeculectomy. Therefore, we're proposed to have intraoperative and postoperative use of mitomycin to prolong the anti-inflammation effect from the antimetabolic agent mitomycin in this situation to prevent fibrosis and lower intraocular pressure. We have a retrospective study suggests a high long-term success rate and a lower rate of hypertensive phase when we use antimetabolites during the surgery and post-op in the post-op phase with the antimetabolic agent. So in order to further study this question, we conduct a prospective clinical trial armed with mitomycin trial. The purpose of this trial is to investigate effect of intra and post-operative mitomycin C on surgical outcomes of almond glaucoma valve implantation. So this is a multi-center prospective double-armed RCT. On one arm, patient received subconjunctival mitomycin, 0.1 ml with concentration of 0.4 milligram per ml, intraoperative and postoperatively. The control group received a balanced cell solution BSS. Here's the inclusion and exclusion criteria. The protocol is to receive injection of mitomycin or BSS, balanced cell solution, during the surgery at 1 week and at 1 month. We use almond FP7 for all the patients. If intraocular pressure greater than 10 at any follow-up visit, aqueous suppression medication will be started in either arm. We hold the injection if intraocular pressure less than 5, or there's choroidal detachment, or there's a shallow or flat anterior chamber. So here's the baseline characteristics for both groups. They are balanced, except that there's a mild change, small change. The balanced solution group, BSS group, has a slightly older age compared to mitomycin group. Otherwise, they have a comparable pre-op intraocular pressure, glaucoma medications, and other baseline characteristics. So here's the intraocular pressure from a baseline until a 1 year follow-up. we can see there's a significant difference at intraocular pressure at 1 month postdoc. So mitomycin group has significantly lower pressure compared to BSS group, which is corresponding to hypertensive phase. The number of topical anti-glaucoma medications are significantly less in the mitomycin group at months 2, 3, 6, and 12. We also look at the visual acuity at 12 months. We studied the percentage of patients with 2 or more than 2 line loss of Snellen visual acuity. Mitomycin group has a 6%, and the BSS group has 20.5%, with p-value of 0.06. Complications at 12 months are comparable between both groups. We also calculate success rate at 12 months. The definition of a success rate is listed below. And we find out the mitomycin group at the 12 months has 85% success rate compared to 67% success rate with BSS group with p-value of 0.04. So in summary, this is the first RCT to examine use of mitomycin both intra and postoperatively. Intraocular pressure was significantly lower at month 1 in mitomycin arm, corresponding to hypertensive phase. Number of topical medications was significantly lower at months 2, 3, 6, and 12 in mitomycin group. It's safe to use intra and postoperative mitomycin with 12 months follow-up. So this is our current regimen. We use intraoperative injection of mitomycin, 0.4 milligram per ml for 0.1. We also do post-op injection with the same concentration at week 1 and month 1. We hold off injection if there is pressure is too low, or if there's choroidals, or there's a shallow flat chamber. Be cautious of the use of mitomycin for patients with uveitic glaucoma or patients with immune insufficiency. Here's a short video to show you how we use intraoperative mitomycin injection. We inject the mitomycin over the plate by the end of the case. Here's a short video to show how we use mitomycin injection during the post-op clinical follow-up. So first, we give a patient a topical anesthetic agent. And then we soak the cotton tip with 4% lidocaine and placed over the plate to numb the area very well a couple times. And then we injected the area with 1% lidocaine over the plate to create a bleb to further numb this area. And after that, we inject mitomycin into the bleb we created to give the mitomycin injection. After we finish both injections, we rinse the area very well with a BSSS solution. So by the end, I want to acknowledge the grant funding to support all the studies and all the parties involved in the trials and all the studies. And thank you for listening to this talk.